But let me start defining the scope of this discussion. I think the clinical relevance of a sick child, as we are going to discuss this afternoon, is to assess a degree of physiological derangement that may endanger life. It's very important to realize that more often it's not the disease that puts the child's life in danger, but it's just the physiological derangements that accompany an etiological agent or a disease. And therefore, many times we need to address this physiological derangement which causes this child to be sick, more importantly than just merely trying to diagnose the cause of the disease. Well, we are all aware, in children in particular, early recognition and anticipation is vital to prevent the morbidity and mortality. And therefore, in general, we need to monitor the vulnerable child even when the condition is undiagnosed. And I'm sure many times in the first few days of any illness that the child comes to you with, essentially one may not have any kind of working diagnosis at times, and surely not often a correct diagnosis. Even then, it's very important to be sure that there is no physiological derangement occurring in that child. And of course, if you had a clear diagnosis, then it is much easier that you are looking at a specific physiological derangements. And therefore, the scope of today's discussion will really cover areas of physiological derangement that may endanger life of the child. To understand this kind of derangement, it may be proper to see what are the physiological priorities of health. I'm sure each organ in our body is important. And once all organs met together and each one thought that he was the most important to sustain health, the brain said it monitors everyone. The heart said it beats and therefore you are alive. The lungs said I oxygenate you, that's why you are alive. The stomach was certainly there to say it's me who provides you nutrition. The liver said I metabolize all that for you. Kidney said I excrete so that you remain healthy. And finally the anal opening raised its hand and said I'm most important. All organs laughed, like you all laughed. And then the anal opening got annoyed and mad. It stopped working. Every organ got frustrated, in trouble. And finally, after a few days, they said, look, you are also equally important. There is no question each organ has a priority, even then. Therefore, when you look at the sick child really, what is the health that is maintained with? Well, you need oxygen and you need energy to remain healthy and free of sickness. And during sickness, you need to assure that you have enough oxygen and enough energy. Well, energy can be stored, but I do not know why the research and development department up there in the heavens have not found a way to store oxygen. It's so vital for health, and even then it's just not stored. And therefore, we need a continuous oxygen supply to remain healthy. Naturally, if you are looking at anything that may endanger life in any condition, you need to be sure that you have adequate supply of oxygen. Now, who provides oxygen? The lung is a provider. The hemoglobin is a transporter. Circulation is the vehicle. The heart is the driver, and the brain is the controller. Naturally, if you need to be sure that you are oxygenating well, you need to have all these conditions satisfied, and all these organs which play direct, indirect role to maintain good oxygenation and health, well behaving. That's not enough. Your cells must have an ideal environment. And who provides this ideal environment? Largely the electrolytes and the pH, the acid-base status. If that is upset, even if you provide enough energy or oxygen to a cell, the cell may not be able to take it. That's why you need a good cellular environment. And of course, you need somebody to take care of the waste disposal. And that's your kidneys and the lungs who would not allow undue, harmful substances to remain in the body. Once we understand, therefore, that these are the organs of priorities, Not that any other organ is less important, but it can sustain life even if it didn't work very efficiently, or at times even if it didn't work for a few days. But some of these organs are so vital that they better work, and they better work continuously, lest the child could really be sick and get his life endangered. Once we know that these are the organs, and these are the organs that support oxygenation, and the energy can possibly be stored, at least for a while to be used, then it's very easy that every child on whom we are worried about getting sick, which means adequately deranged to endanger life, we must really look at the lungs. And how do you recognize whether the lungs are doing its job of taking in oxygen adequately? You have a child who is restless if he is hypoxic. Any child who is restless for no reason, for an unknown reason, for unexpected way of behavior, of restlessness, should certainly arouse us a suspicion that he is sick enough to be addressed to the issues of restlessness. Of course, the increased respiratory rate, the increased respiratory efforts like respiratory distress is all well known to us as a real danger of sickness. At times, aphonia, a child who is not working well in terms of respiratory muscles may not even be able to voice his respiratory distress, and he is aphonic. Any child who has got a respiratory distress but even cannot voice his distress. Majority of these children are irritable, cranky, they cry. It's difficult to keep their cry controlled. But here is a child who cannot even voice. And if that is so, that spells a big danger. And unfortunately, he is not able to voice even that danger. And therefore, many of us may be very casual in looking at a child who is otherwise quiet. Too much quiet child is also not good. And this is the way we really look at where the lungs are functioning well. What about the brain? You don't have to wait till he gets unconscious or throws up a seizure. Everybody knows the brain is somewhere disturbed. But a mental confusion. I recall a child of pneumonia who was not going to die because he didn't get the right antibiotic. But he would have died if he didn't get oxygen to his brain. His brain was craving for oxygen. It was demonstrating by a mental confusion. And here was a sick child who would not even recognize his mother who was standing by the side of the baby. And that kind of mental confusion is an early warning that he is sick enough and he needs oxygen urgently. Of course, then he gets drowsy, he may be irritable to begin with, he may have symptoms and signs of increased intracranial tension. And all those are not difficult to make out. We are all well ingrained into picking up such symptoms and signs. But many times a subtle symptom of mental confusion should warrant us enough to say there is some encephalopathy, whatever the cause of that encephalopathy, and it could be just any metabolic issues. The circulation is very, very important, and it's a good idea to make sure in every child who looks sick, of whom you don't know the correct diagnosis, that his circulatory status is good. A capillary refill time that we all know are a good way to be sure that the circulation is fine, and a core skin temperature. I'm sure all of us must have seen children who apparently have no fever, but if you take a rectal temperature, they're really burning hot. There is a tremendous core skin temperature difference, and that difference spells out a rather serious condition, that you have a large core skin temperature difference, and then you know you may be in trouble. Blood pressure, unfortunately, is a little late event to occur. Though in a little bigger child, you could consider to test for a postural changes in blood pressure. And if you have a stool-going big child, his early parameter could be a change in a postural hypotension, and that may be a good clue to say that his circulatory status is going awry and you need to pick them up. But in most of the younger children, it's important to realize that blood pressure really goes down very, very late in the course of sickness. And if one waits for the blood pressure to go down, you're already often very, very late. Of course, we go by the heart rate, the rhythm, and the heart sounds, the quality of heart sound. You could suspect a hypokalemia just because your heart sounds were soft and muffled and your heart rate was fast. It was good enough to say that something is going wrong with the myocardium. Many times we may call vaguely this as a myocarditis. After all, we use some of the etiologies just to hide our ignorance. Virus is one, and allergy is another. And sometimes we call idiopathic. You know what the term idiopathic means. It's a pathetic condition of the patient due to idiot doctor. That's idiopathic. And we all use this term to impress that we know the final diagnosis. Of course, the kidneys are very important in terms of urine output. But don't forget, if the urine output is too much, even a polyuria could spell trouble, as you would recall sometimes a diabetes mellitus or insipidus, coming with large amount of urine. And it's fine to expect in many conditions a urine output going down, but a urine output going up as well might spell sickness that you take care of. And of course the hematological conditions like largely the pallor and the purpura, and I'm sure for the purpura you need to look at the skin carefully all over the body. Who undresses the child? Almost no one. Often the parents are very, very observant and they bring out a purpuric spot to you and you say, of course I have seen it. So it's important that you really see a child about whom you don't know what's happening, that you evaluate certainly a skin for a purpuric spot, and pallor often would be just striking at you. It's important to see the muscles. The muscles could be skeletal muscles, and you need to look at a hypotonia, an unexpected hypotonia, or even a weakness that the child likes almost hypotonic frog-like posture. You'd know that the muscles are suffering. You could have a cardiac muscle, of course, suffering, and at times you could have smooth muscles of the intestines also suffering in terms of an abdominal distension or a decreased peristalsis. And you know that if all the muscles are taking the brunt of this kind of a sickness, then you are probably on some metabolic disorder like hypokalemia, for example, or even a muscle weakness due to hyperkalemia. None of these conditions can be just picked up clinically, but surely could be suspected. And if they are suspected, then only one could investigate them further and get to know what next to do. And therefore, make it a routine quickly to go through these in every child. I'm sure those who maintain this routine practice of looking at all these factors very quickly may not need to spend even a minute to get to know that each organ is doing reasonably well. And if you suspect and focus on a particular organ not doing well, then I'm sure you can get into more details to be sure whether that organ is really at fault and needs support. It's very important, therefore, to assess the severity of such physiological derailments and, of course, observe progress. If you know that what you observed is seemingly getting better, then we know that we have a time on hand to wait. But again, to reiterate that the children may die not because of the etiology or the primary disease. They often die because of the organ dysfunctions. And one organ dysfunction starts first. If not picked up, you have a multi-organ dysfunction, easy to make out, most difficult to treat. After all, in clinical medicine, what is easy to make out is really difficult to treat. Because it's easy to make out because it's too late that you have made out. And if it was not easy to make out, probably it was easy to treat. Therefore, it's quite a situation that what you can make out easy is very difficult to treat. And let's make sure that we pick up what is difficult to pick up rather easily so that the management is rather easy. Well, we can't just go on doing this kind of a protocol in every child that you meet in your office. Somebody comes with a nasal discharge which looks allergic rhinitis or viral rhinitis. You may not consider him very vulnerable. And therefore, you need to certainly do this kind of a quick mental note and a clinical examination, at least in a vulnerable situation. And what are the vulnerability for sickness? Younger the age, the child is likely to be vulnerable to be sick very quickly. Malnutrition, of course, adds on to the risk of getting sick. And both these conditions, the younger age and the malnourished child, often does not demonstrate symptomatically what a little bigger child may, but surely the physical signs may pick them up as well, even if they do not suggest this in terms of symptoms expression. And therefore, in a younger child and a malnourished child, we cannot wait for a symptom to be addressing the issue of sickness. We need to pick them up even much before they voice their symptoms. Immaturity, of course, of any kind, which is either a very small preterm baby who is immature, or the child who could be really a defective organ, and therefore that organ is immature, would certainly pose a problem. And I'm sure the moment you have a specific issues like immaturity or a defective organ, then you know where you stand and you focus it very well. But what is more important is that even when diagnosed conditions can be considered potentially serious, for example, if I have a child of pneumonia, I know he can get into any trouble. I need to be very sure that he is not getting sick. A pneumonia may not be sick. You can treat him even in your office practice, in an outdoor practice. It's the sickness that endangers his life, and that needs really a hospitalization. But what is most important to a clinician is the undiagnosed illnesses. And I'm sure if you are true to yourself, you have more often undiagnosed illnesses in the first few days of any illness. Many of them get better without the diagnosis, and you call them virus, etc. And those who you diagnose, generally diagnose beyond 3-4 days, and you diagnose them because they go into trouble. And it is evident that you have a diagnosis. Haven't we all seen a dengue only after it gets into a hemorrhage or a shock? Who can call a dengue without a hemorrhage and shock? He looks similar to many others. And haven't we seen a cerebral malaria who never looked malaria yesterday, and today I announce, oh, you have a cerebral malaria. It has to be there for a reason to pick them up early, more so if they are undiagnosed. Let's quickly go through a common diagnosed conditions which can be potentially harmful. And the gastrointestinal infection are a classical one, where you're not worried in a gastroenteritis how many stools the child is passing, which is what the worry of the parents is. But you're more worried about the symptoms and signs of dehydration or hyponatremia as suggested by lethargy. You are happy if a child of a diarrhea is an irritable child and averagely consolable child. If he is lethargic, you are in trouble. However, if he is excessively irritable, that he cannot be even managed, he could as well have a hypernatremia. And that may be just a clue that you have a child who has diarrhea and an excessive irritability. Of course, if he looks tachypneic, we all know he's acidotic. Problem is, how do you pick up tachypnea? None of us have time to observe respiratory rate for a minute, but I'm sure all of us have eyes to suspect straight off in the first second that this child's respiratory rate needs to be monitored and counted. That is good enough to pick such an tachypnea. Then you may have an abdominal distension, of course, in a diarrhea. If a child of diarrhea has no abdominal distension, you're okay, even if he passes 20 stools. But if you have an abdominal distension, you're worried because it could be obviously hypokalemia, a paralytic ileus. And it's very, very important that if he gets suddenly better, if a child of diarrhea who is passing 20 stools, you touch your hand and give some medication, even not required. And the mother phones to say, wonderful doctor, wonderful medicine. His stools have ever since stopped. Doctor, your hand is too great. You should be aware. None of us have such a great hand. It's silly that parents say, oh, your hand is so good, which means that they don't consider our brain to be important. That's a pity. But anyway, we pat ourselves and say, yes, I always cure patients first. You know that you are in trouble if there is a sudden improvement. What's the message? In clinical medicine, nothing gets well suddenly, except those conditions who would have otherwise also got well suddenly, like an allergy. So you need not pat your back and say, oh, he got well suddenly. And then, of course, if he has a bacillary dysentery, blood and mucus, he is febrile, he is toxic, he could get you into a toxic encephalopathy. If you are unlucky, you can get into an HUS. And therefore, it's not that every child is going to do that. But you need to be very, very patient and very observant and say that, look, this is a potential troublesome condition, especially when you push the age and the nutrition onto it. Respiratory problems like pneumonia, every child of pneumonia who is in a mild respiratory distress is irritable. You need to pick up his mental confusion. When he starts getting drowsy, he's getting much, much more hypoxic. And I think that's the time that you're going to get into trouble. You could have picked him up right when he was just an irritable child, and then he got a little confused. Of course, he has a chest retraction, increased respiratory rate, accessory muscles working. He has an increased work of breathing. He has an increasing respiratory distress and a rate, and finally he has a seesaw breathing. Well, that's too late. You could have picked him up right when he was just an irritable child and he was a little confused. When you talk of asthma, we all know we have an excellent modules prepared and the protocols prepared for asthma management by our pulmonology group. And any asthmatic who is unable to talk, he is unable to drink or sleep, is a child who needs to be observed. It's not just the wheezing, it's not just the coughing. And what are we really looking at? We are looking at the function of the organ. We are not looking at the etiology or the disease process. We are interested in a functional impairment of each disease. And when you have a primary febrile illness, like a malaria, it's certainly difficult to pick up a malaria which is going to get into trouble. But if you have a malaria with a parasitic index which is high, you have a malaria who looks a little drowsy, you have a malaria who has a little jaundice, a malaria whose urine output is a little low, or a malaria who is a little tachypnic, I'm sure that he is already getting complicated. And such a child surely needs to be very closely monitored, observed, treated in the hospital setting, because he's going to get you into trouble. Many of them, fortunately, may just revert back. And one could see a jaundice in malaria not uncommonly. And surely not everyone is going to get into trouble. But that jaundice is telling you that the malaria is getting complicated enough. And how are you sure that it's not getting into the kidney or the lung or the brain for that matter? The liver can tolerate a little nonsense with malaria, I'm sure. But not the brain or a kidney or lung for that matter. And therefore, you would diagnose such conditions as complicated malaria, and they are sick children. Even if they do not really express their dysfunctions of various organs as of at one time, surely they need to be very, very closely monitored. And then a word about dengue. I'm sure that dengue has been raging all over, and it's really a very troublesome situation. It's fortunate that majority of dengue fevers are unrecognized, and some of them are recognized as just fever and rash as a viral infection. It's estimated that just of 1% may really go into a shock syndrome, and maybe about 5 or 10% may come out with a hemorrhage. It's enough therefore for us that every time I call an infection a viral, and I tell the parents that, oh, don't worry, the viral infection gets better on its own. I know in the bottom of the heart that this viral infection can get me into trouble, and I need to sound the parents, if you're doing an outdoor practice, that in the event of any such thing happening, you need to really get quickly onto the doctor. We are all aware that we don't lose dengue if we are right there. But what is most important in a fever like dengue is a peri-defervescence period. And I think it's the peri-defervescence period that gets you into trouble. Here is a child who has got fever rash. You call it some viral infection. You don't know it was dengue. He gets better. His fever is less. And the parents feel reassured that he did get better on its own. And you are also relaxed. It's at that time that he gets into a hemorrhage or a shock. Therefore, this kind of an illness is worse at the time when he's getting better. And I think here is one example where a clinician would monitor a child's sickness very closely, not at the peak of illness as much as at almost a defervescence. And many children therefore would come back with a vengeance, and they said, but yesterday the fever was just not there, and I thought I was getting out of viral infection. But at times we have an undiagnosed conditions. And I would just end up my talk with common undiagnosed conditions that we see. And one of them is fever. If any one of us writes an antibiotic to a fever in the first 48 hours, he's most likely irrational. Because you cannot diagnose a bacterial infection in the first 2 days, unless you have a frank tonsillar pus there or a otitis media flowing pus. Otherwise, there is no way a bacterial infection can be diagnosed in the first 2 days. And therefore, it's not easy really to pick up which fevers are going to be troublesome 4 days later. And don't you all call first 2 days fever as viral, next 2 days malaria, third 2 days fever may be typhoid, thereafter a week later maybe TB, thereafter a malignancy and a collagen vascular disease. Most of the patients don't stay by then and have seen somebody else who unfortunately may start all over again the same way. That's where we come into trouble. How do we pick up a sick fever? By disproportionate heart rate and a respiratory rate. If the temperature is not very high, but the heart rate and respiratory is much higher than expected, you know he's getting into early sepsis. You pick up a circulatory failure signs like an increased capillary refill time and so on. You look for the purpura, you look at a lethargic child, You certainly look at the respiratory rate and the chest retraction. You look at the abdominal distension. It may be an acute abdomen in a child or a facial membrane saying diphtheria. What did we do in a child of fever? Just recall the earlier slide where we were looking at the vital organs keeping health and a deranged physiological functions of these organs getting into sickness. We just pushed the same thing here, and we tested the brain, we tested the lung, we tested the circulation, we tested the abdomen, and we said, if you are all right on all these fronts, you are not sick with fever, even if the fever is 104 and higher. For many parents, higher the fever, more the sickness. For you and me, if these are the symptoms and signs with fever, then that spells out sickness and not really anything. Many times children may see you for generalized weakness, and which mother does not feel her child is weak? And therefore most of us take it very casually. But if a child who has suddenly started feeling weak is a very, very important situation, and sometimes it may just mean that he is coming with hepatitis, but most important thing that you might miss is a diabetes. And I recall few times the diabetic children coming to you only because they are feeling weak. The parents say that he comes home and just drops his books and lies down. Doctor, he never did this before. I think that's a warning to you that something is terribly going wrong. You examine this child, you find nothing. And who would examine him for a possible diabetes? You ask for a polyuria, yes, it's there. And you get a blood sugar at maybe 500, he may be already ketonuria. It's easily missed. Because anybody who says, my child is weak for last 2 years or since birth, you may forget it. But if mother says, my child is weak only last few days, I think really get into that very well. Hypokalemic child come with marked general weakness. And who takes a reflex? Reflexly we forget to take a reflex. And therefore, I'm sure the neurologists take a reflex. We are all non-neurologists. We don't take reflex. We reflexly act. And therefore, many times such things are missed. What's the bottom line? If you do not know what to do, you do everything. What an undergraduate would do, and probably you won't miss. And sometimes you see a child who is excessively crying and irritable. And what do? You put your hand on the abdomen and say, oh, it's a colic, don't worry, and give some antispasmodic. You are sure you can't palpate a colic, but the parents don't know that. And you hope that some medicine works. It may work most of the time, because most of the time you didn't do anything, it would work. But at times you could be in trouble. Therefore, even when the child is irritable or excessively crying, a single question to the mother, has he been like this irritable? She says, no doctor, this is something different, believe her. And one would pick up hypoxia, hypernatremia, and a hypercalcemia, simply by such symptomatology. And I recall a child who had a hypercalcemia. He was irritable, he was anorexic, he was vomiting, he was polyuric, he was constipated. Clinical examination would not show anything at all. And how would you just do serum calcium when you don't understand anything? We do serum calcium in a newborn when we don't understand anything. Because the newborn protocol demands that you do glucose, you do calcium, you do routine septic workup, and you still give the same antibiotics, oxygen and IV fluids. But not in a bigger child. And then sometimes you may have a non-localized pain. I recall occasional children who had a severe neurogenic pain and he was crying, irritable. The mother says, doctor, you're missing something. I said, no, I can't find anything. And you wait for a week or two, you find a knee jerk gone. You know that you have something in the spinal cord there. You do an MR, you have picked up a tumor which was pressing. Point I'm making is that anything that you don't understand really is something that you believe the mother and you go through your undergraduate way of physical examination. As the time goes, very casual, and therefore, in situation we don't know. Just do this profile. You look at the blood, electrolytes, blood glucose, creatinine, the oxygen status, ADG, etc., and the coagulation profile, etc., could be optional. What's the take-home message of all that I said? Physiological derangement resulting from organ dysfunction endangers life more than just the cause of disease. Haven't we seen people changing antibiotics but not giving adequate thought to an organ dysfunction and say, I tried all antibiotics but they failed. None of the antibiotics failed, but something else failed. And while curative treatment of disease is very important, life can be saved only by preventing or treating physiological derangement, which offers time for curative treatment to work. Thank you very much.